I will tell you that, and it's interesting because over the last day or so, in talking with the people that have come here to see us, this has become sort of the subject to talk about. And I will tell you nothing in this industry is being talked about more than reference-based pricing, value-based payments, and paying providers according to Medicare. Everyone's talking about it. Lots of people are doing it. And what's interesting about it is that it's such a new phenomenon. There's a lot of newness to it, and there's a lot of things that people don't know about it. And it's a very disruptive program, and these panelists will tell you that. It's really important that you know what it is and how it works and what you're doing with it if you're going to make it work. So we've assembled a panel of people who know collectively probably more, not probably, I think for sure, more about reference-based pricing and value-based payments than anyone in the industry. So these are the experts, and so you're lucky to have them. What I really want, and of course I've got a whole series of questions to ask them, but what I really want is for everyone here to ask questions, because I know it's on your mind, and I know you want to know more about it. So if you would, feel free to raise your hand, and we'll have Krista and Sharon come over and give you the microphone, and hopefully make this an interactive discussion. But let me introduce the panelists. Ryan Day from HST, Jim Henry from Izzy, Cori Cook from CMC Consulting, and our own Holly Weiske, our Vice President of Client Management at Cypress. Again, these are the people who are on the front lines, and they're into it on a daily basis. So different perspectives in that Ryan, of course, runs the company that does this. Jim is a stop-loss carrier and has the costs on the back end. Cori, as I think we established yesterday, is the strongest attorney in the industry. That's why Tim Callender left. And Holly works with clients on a day-to-day basis in getting this implemented and having it work. So we're very excited to have the panel here today. So I'll start out, I guess, maybe we should start with the basics. And Ryan, if we could ask you, kind of give us VBP 101. What is it? How's it work? Don't take up too much time, though.
No, I'll keep it very brief. For those of you who don't understand what reference-based pricing is, what it is we want to understand what you're getting a discount off of. A carrier will walk in and say, I got a great discount, and we'll say, well, what's it off of? And then people just look at us. So what reference-based pricing is, what are other people paying for that service? What does Medicare pay for it? What does it cost a facility to provide that service? And now we can start our reimbursement from there. So we're going bottom up versus top down, how it currently works today under the current network arrangement. So it's really a reimbursement based on a Medicare Plus type model for your facility services.
So, and maybe we can kind of ask everyone this question, because now we've kind of set the table generally. For those of people who don't know in the audience, talk about growth. What are you seeing out there? How's it going? And is it accelerating? So tell us what's going on. So if everyone can kind of answer that.
Yeah, I think as far as growth and what we're seeing, I would say early on it was more of the adopters, but now the more we see it for us, for our 1-1 activity, it was about 65,000 employees for employer groups that we brought on, and it was all walks of life. And I think the one thing they all had in common is they want to manage risk. They're tired of writing checks. My clients aren't the check writers who just heads down, let's just keep paying and doing what we're doing. It's people who are saying, hey, this is unsustainable. And I think with a lot of the news that's coming out from Berkshire Hathaway and those folks in Amazon, well, what do you think they're doing? They're like, listen, we're not going to play this game with the middleman who tells us we can't see pricing. We need to start doing things differently. So it's very interesting to see employers and how they start thinking about their own money, because this is the only industry I know of where it's just like, you give all your employees American Express black cards, and it's like just off you go. Don't worry about price. You have the care. So now we're starting to have some more accountability related to that at the end of the day.
Let me say, as the risk taker on the panel here, we absolutely love the VBP concept. I've been doing stop loss a long time, and this is the best thing I've seen to manage a plan's cost. So no big surprise, I'm sure.
And can you give us an idea of what kind of growth you've experienced?
Yeah, it's been a great growth product for us. We started writing it about 5 years ago, and it now makes up about 25% of our book of business. but it's about 50%, close to 50% of what we're writing in new business.
Yeah, yeah.
And I think it's growing for a number of simple reasons. The most important is it works. Claims keep going up, and this product works. And I think also it's being talked about a lot.
Yep.
Conferences like this, you read the articles, industry articles, or industry blogs, social media, is always information about reference-based pricing. And another dynamic, I think, is we're seeing employers are seeing this for the second or third time. And a lot of what we're writing are employers who we've quoted on in the past, and they're now finally deciding to adopt it.
Yep.
Speaking for the stop-loss market as a whole, I think now most carriers and MGUs are writing it, or at least attempting to write it. That wasn't the case a few years ago when we first started writing the product. I remember being at an industry conference, I think it was a SIA about 4 or 5 years ago, and there was a panel like this made up of all the biggest stop-loss carriers. You can probably guess who those were. And the question came up about reference-based pricing, and it was rather lukewarm response. It was kind of, maybe a bit of a fad. We'll see, we'll kind of sit back and see what happens. And I'm glad they did, because it was a great opportunity for us.
All right, cool. Well, and I'll get back to that with you. Interesting. But Cori, so on the legal side, you do as much or more than anyone else in the business about that. How's business going?
Business is great. I don't, now that I'm out of the TPA world, I don't track lives anymore, but every single client I have on the legal side has some form of RVP built into their plan design at this point.
Awesome.
Across the country.
And Holly, everyone will notice that Holly's the most tired-looking panelist because she has to deal with all of you all on a daily basis.
Yeah, so I would say that every single meeting that we're in talking to employers, this is coming up. They're asking us how it's going with our in-force clients. They're talking to us about, conceptually about how to structure that program, what it looks like, if it's right for them. I think importantly, we want to make sure that when you're implementing a program, you understand what you're getting into. And in spite of that, it's hard work. It's a lot of education to clients. But we've seen 16% of our clients adopt the value-based program concept, which represented 23% of our business or our membership in 2017. Yeah. So that's up an additional 6% from last year. So it's just growing. And interestingly enough, people talk a lot about what's happening on the claim side. What are you seeing in terms of member pushback? There's a lot of conversation, obviously from a member perspective, when they are in that balance bill situation, so we hear from them. And when we looked at the numbers, it was kind of shocking because if you have 1,000 claims that you're paying, you have 100 that are repriced, that are facility claims that are getting repriced RVP. Of those 100%, or of those 100 claims, only 3.43 of those claims make it to the PAC. So people are getting balance billed on 3 of those claims, and 1% from 2017 are unsettled at this point. So it's talked about, and it's a big deal to those patients, and it takes up a lot of time to educate and continue to move those people, through the process. It's tedious, but it's saving people a lot of money.
Yeah, so, and I want to get into that a little bit in a second, but I guess maybe, again, just a real general question for everyone. If somebody from the audience came up to you and said, okay, what does my plan need to look like? How do I even put something together? What are my benefits? Do I use a network? Do I not use a network? How's this whole thing work? Do you have, and understanding that in the self-funded industry there's no such thing as a template, but do you have suggestions for people on, at least out of the chute, what their plan should look like? Ryan, you do it more than anybody else, so what do you like?
Sure, I would say the template is putting a PPO in place for the physicians or doctors or your specialists, your everyday visits that are, high volume, low dollar. That's typically, what most of our groups do. I'd say 99% of them do that for that familiarity because everybody's in this room is used to having a PPO logo on their ID card. So it's that same familiarity. And yes, there are some gaps compared to other Blue Cross, United, Cigna, Aetna networks. But at the end of the day, They usually keep that in place, and then what they'll do on the facility side, that's when they'll apply the reference-based pricing, so the Medicare Plus and all the facility service, because that's where the big dollars sit that we all know and understand. A gentleman to the left of me will tell you that's where the big dollars sit too as well for him. So that's where we're seeing a lot of that activity, and that's how majority of the groups do it. We do have others that go full replacement, but that's kind of another, usually once you're into the whole program and you've got a few years of experience, then it would make sense to kind of take a look at the whole thing. So that's
Jim, how about you? What are you seeing on the stop loss side that's working?
Well, for us, we need to have certain structure in place for it to be a successful program. And what Cypress and HST has put together has all the proper pieces to it. It's got to be right plan document wording, good employee education, a good patient advocacy, balanced bill management type of process, and then parameters for negotiating a claim when the facility won't accept the percentage of Medicare. And then experience in the product. Because we've been focusing on this for a while, we do have a number of people come to us for quotes of this product, this type of product. And we won't quote on a VBP type opportunity unless we've fully vetted who's going to be doing the repricing, the experience of the TPA, all those things. So those are all the important components that we look for in a program.
Okay, Cori, how about you? What are you seeing?
So from a benefit design standpoint, I don't think there's one thing that fits all employer groups. For my clients, the majority of them are full RBP, and I don't think that is necessarily the norm. I think most of the clients that are doing RBP across the nation have a physician network and some other contracts in place and not necessarily going all in. So plan design being one thing, the structure of the plan and the language of the plan and the documents that flow from this process are essential. And from an industry standpoint, we're still a little messy. I'll be honest with you. When you have an RBP plan or any plan, it actually needs to be kind of read through with a fine-tooth comb. You cannot go to an RBP vendor and place their language in your plan document and you're off to the races, because chances are you're going to have conflicting language elsewhere that you need to address. How the payment is going to be, how the claim is going to be paid is essential. I saw one the other day that came across my desk. There were literally 17 definitions within the plan on how to pay a claim. Under ERISA, a plan actually has to be understood by an average person. And if it gets to me in a dispute and I can't even determine how the claim should be paid, we have a little bit of a problem. We can't have maximum allowable payable, allowable amount, UNC, CNR, UCR. I mean, the list just goes on, and these documents get so messy that by the time I get involved on a dispute, the administrative record is a train wreck. And that's really, like I mentioned yesterday, that's that golden ticket to survive in a court. So what the plan language says with regard to payment, what it says with regard to who can be an authorized representative and how they become one, what it says about assignment of benefits and how they're going to be treated and if they're conditional, what that EOB says in relationship to how that claim was paid. You can't be a TPA and have clients that do RBP and not RBP and have one EOB that satisfies the needs of all. It has to be specific. That ID card's important. The whole chain of events needs to be singing the same song so that at the end of the day, we are in a good position to defend these because they are certainly worth defending at this point.
Yeah, awesome. And Holly, what are you seeing for our clients and what's working for them?
Yeah, and I couldn't agree with Cori more. I think every single employer is going to structure that plan differently based on their employees. I mean, that's part of partnering with the TPA, right? You want to make sure that you're coming to the table and figuring out what makes the most sense for your individual employer or employees. We see what works best. Again, putting in a PPO network for the kind of low-hanging fruit. We think it's imperative that you reach out to your employees and explain why you're implementing this program first and foremost. Explain to them, that you're doing whatever you can to put in contracts in place that are going to hit that low-hanging fruit, like the physician consultations. A lot of employers are putting in teledoc. They're putting in, a lab contract, one call for the radiologic stuff, a transplant network, dialysis programs. They're putting in cancer care. They're trying to navigate, or trying to get the member to navigate to a program that has some sort of concierge type for them, so that they can, those people who have high cost claims, can navigate through the system and have some sort of concierge program. And then the low-hanging fruit is taken care of. Let the HSTs of the world deal with the large, egregious hospital bills. That's what this is all about. So we do we've seen a new strategy kind of come to play, in that employers are starting to minimize what the employees are paying. So their out-of-pocket is being eliminated. That's been big. So if you can figure out how to structure your plan where you're telling your members, hey, I need you to jump on board and help me manage the cost of claims, but what we're going to do for you in return is give you, access to this care without any out-of-pocket or cost share. That's huge. And it gives HST some leverage in terms of when they're going to negotiate that. They're saying to the provider, look, we don't have any other balanced bill that you need to collect from the member. Let's come to a fair and reasonable price tag on these claims, and we'll give these members access to this care without any cost to them.
Yeah,
so
that's an interesting strategy, isn't it? Because we've been used to the last, 15 years, deductibles and out-of-pockets going up, and all of a sudden now we're talking about a program that we're essentially eliminating out-of-pocket for employees to get them to buy in, right?
Yep, exactly.
If people are willing, do people look at you like you have lobsters crawling out of your ears when you suggest that?
But and when you look at it, you're saying, really, your members are contributing right now, 8 to 10%. You're saving 30 to 40 to 50% in your total costs. Why not give back a little bit and create a strategy that's going to keep everybody happy?
All right, I want to follow up on because everyone at this panel talked about putting, so you pay hospitals according to, Medicare plus a certain amount, but then putting in place a provider network. Give me real for a second about the provider networks, because there are only a couple that you can access, right, that allow you to eliminate hospitals from their network, but also be able to take advantage of the doctor contracts that they have. Is that the right strategy, or ultimately do we go to just getting rid of networks? Because all I do is talk about how bad networks are, so it's hard for me to support that. So what do you think of that?
I would say from our perspective, 2018 we are seeing more and more requests to get rid of PHCS is the typical one that most folks are using. They'll allow you to use the physician only. But folks, where the rub kind of comes in on from the employee membership perspective is my doctor's not in the network. And so then I get associated with it, even though I'm not with the network, but it's part of RBP for that instance. So we're saying, okay, well, let's go full RBP at this point and pay the doctors a Medicare Plus number. So that way I don't have to hear about my doctor's not in the network. It's the same concept, go where you like, it's open access. So that's where communication is absolutely critical on this whole panel, especially from the TPA side of when, doctors are calling in, you can start quoting pricing up front where they say, hey, Medicare at 120 relates to, hey, that's $200. Got it, that makes sense, yep. Let's move on from that perspective.
So is Medicare at 120 the number for doctors?
Typically, that's what we see. It depends where you are in the country. Some may be 150, 160, some are 140, so it depends all over. But our benchmark that we see across the country is 120, 120% of Medicare.
And Jim, what do you think?
Yeah, Tom, from our standpoint, we've got business that has both carved out networks on the professional and ones that run all of it through. And our pricing is very similar on both of those because of what Ryan was saying. Most of the fee schedules on the professional are pretty close to the 140, 150 of Medicare. So there isn't really a lot of savings if you've got a good network. What I see sometimes is the problems that the plan has where we put this in place to focus on the facility, the big dollar items. The problem the plan ends up having is my doctor's not in the network, or there's friction on the professional piece, and that ends up causing a problem with the whole program. Mm-hmm. And so that's one thing that I would say I would make sure that if that's happening, I'd look at doing the full replacement.
And Holly, do we have any, I should probably know this, but do we have any clients that go full replacement?
We have a few. First year, we're telling clients, don't do it. Just because you show that ID card to your provider, and I don't know about you, but every single time I go to the provider and I show my bill or show my ID card, they're like, oh, you're with PHCS. Well, no, my plan's self-funded through my employer. But they look at your coverage as the network. So just to get members in and through that treatment process, you know, it's too hard to educate billing companies too, or billing entities. So from our perspective, you know, put the network on the card, you know, give the member access to some sort of contractual arrangement, you know, if they hit upon a provider who's in that network, you know, again, minimize their out-of-pocket. We think at least first year you should put in a network and associate the plan with a network.
All right. Anyone disagree with that?
I don't necessarily disagree, but I'll just give a contrary opinion just so that we kind of see the whole picture here. So it kind of depends on where you're located. We do have the issue, or most of my clients are, with either not the inability to contract directly just for those physician claims, or you know, if I have a client that is saturated in one given community, rather than going the network route, one of the other options is to go do a direct contract, so you're not dealing with I mean, I've been complaining about PPOs my entire professional life, so I have a hard time having that discussion with a straight face. So, you know, a lot of my clients are developing their own narrow network to address some of those claims, and even some of the larger claims, to fill some holes within their communities where their members live, rather than going a traditional PPO route.
Yeah, it'll be interesting to see how that evolves over time. Okay, so let's go back to the question about the ideal plan. What's the sweet spot? What do we reimburse hospitals? What do we reimburse? I mean, Ryan, you mentioned 120% to physicians. Is that 90%, 99% effective? I mean, and what do you? And I guess I should ask everyone this relative to hospitals. I mean, we talk. I think sort of the accepted level is about 140% of Medicare, right? That seems to be the thing. Should we be flexible on that one way or the other? What should we be doing on that?
Yeah, I would say when it comes to where we set the reimbursement, it's not like we pulled 140 out of the air and we're like, this sounds like a great number, let's go with it. Believe it or not, we have a lot of hospital clients. Hospital clients are my fastest growing block of business, so you can imagine, you know, what they're doing for their employees, same concept. So that's kind of the first start where they do it on their own employees, and then the next step is going to the employers directly. That's what they want to do, to be able to drive business into their facilities. But obviously, you got to have the price to be able to do that, and you need the quality as well. So those are the two aspects. I'll give you a perfect example. The Advocate Health System in Illinois, they're the largest health system there is. So we have an agreement in place with them where we've got their 6,000 doctors, we've got their 15 hospitals. They will take a Medicare Plus, but the plan's paying at 100%. There's no patient out of pocket. It's zero. So the members can go there. You have your small copay for your ER visits, and you have 2 copays for the physician specialist, like $10 to $20. So it's a different mentality, and we've been quoting this for, I mean, we work with a lot of large unions, and that was kind of one of the things they wanted to do, is go direct to health systems, and that kind of fit the bill. So we're starting to see more and more of that come about, but 140 seems to be the norm. Is that the end-all, be-all for all facilities? No, not by any means. So what we see on our block of business, as Holly quoted, we see on our block about a little less than 2% pushback. It does happen, so anybody who tells you it doesn't, I'm not being honest with you, it does, but it's how you deal with it from that perspective that gives that facility which way they're gonna turn on you. So is it, you know, you draw the line in the sand and say, hey, you better take this 140 or else? That's a way to do it, I get it. Most of our opportunities when we do see kind of that pushback is give us the latitude to be able to negotiate. You know, we need the hospitals, they need us. So at the end of the day, let's figure out a number that works for both parties and not just one-sided. So all the plans we talk about today, when we do see some type of pushback, we are going to have that ability to negotiate between 140 and 200% of Medicare. That's typically our operating guidelines from that perspective.
And so, Jim, you're taking the risk on that. Are you cool with that? Are you cool with letting Ryan just go to 200% when the plan document says 140? Or does the plan document say something different?
Yeah.
I guess Cori should answer that.
Yeah, well, most of what we see is the 140 to 150, and Ryan, correct me if I'm wrong, but we used to always hear at about 170, most of it goes away, the noise. You know, I remember years ago, when we first started seeing reference-based pricing, when negotiation companies like HST started using 200% of Medicare as like a benchmark for out-of-network claims. And I remember when we first started seeing that number and those claims repriced at 200, we'd say, man, if we could just get all of our business at 200%, that would be awesome. And so, yeah, anything 200 or better is great from where we sit. Now, getting back to your question about are we cool with Ryan repricing up to or negotiating up to 200? Yeah, we are. We accept that process that allows HST to go up to 200% without involving us in that process at all. And if we can't reach settlement at 200%, then they can go beyond that. We just ask that we be notified or at least know what's going on. We have not had a situation where we did not end up reimbursing what they ended up negotiating and agreeing to.
Okay. All right, Cori, where's your tipping point?
So for clients that are having them repriced by a vendor, I'm seeing anywhere from 120 to 160 typically. For direct contracts, I see them a little bit higher, probably the highest end being 240. And again, that kind of depends on the community that you're in and do the claims analysis and see how how their billing practices are, see how their quality is, and then make the determination from there. But I did want to touch on what Jim said a few minutes ago, and I see this as a new trend that's somewhat irritating to me, and maybe you'll end up being an outlier, which will benefit you yet again. I'm seeing carriers put their own caps. So we have they're quoting business on an RBP plan, and they're going to put their own, regardless of what the plan says, whether it's 140 or 180 or 160, in their little deck sheet, they have this little memo that basically says, we gave you great rates, and so we're going to cap anything at 2. So you're fine with your plan being at 140 or 160, and you can go negotiate all day long, but we're going to cap our exposure at 200% of Medicare. And I have a very colorful response to that, which I won't share with you now because I was told I'm being recorded. But seriously, you're willing to accept 9,000% of Medicare billed on a PPO contract where we got a 10% discount, and you're going to cap me at 200%? I actually had an MGU call me and ask me if I'd draft the language for them. And I declined. I'm like, no, I don't believe in this. I mean, we're doing the right thing. And his comment to me was, well, what if they just pay bill charges? How am I going to protect myself? And I'm like, you really think an employer is going to go through the painstaking process of becoming RBP and turn around and pay bill charges? You need to go find another lawyer to draft your language. So that's something to watch out for. I think it's entirely inappropriate. Do I think there can be a cap? Absolutely. But when somebody is negotiating in good faith on $1 million claim and saving the carrier money, don't you dare cap me. That's my response.
All right, look at that. Yeah. Cori, could you come here after lunch and say that to all of the stop-loss people as they're sitting on the...
I would love to.
Excellent. So all you stop-loss people, you know what's coming. Get your answers ready.
Yeah, and I've seen some of those caps in there, and I would think that someone doing that wouldn't be one of your recommended carrier partners. Because, even if you end up at 250 or 300% of Medicare, or even 350, that's a lot of what the BUCA carrier discounts are. So, a lot of times you're happy to get that in certain situations.
Yeah, I mean, it's interesting because I saw a study late last year, that showed that, we're talking about 140, 150, up to maybe 200% of Medicare. I saw a study that showed that the Blue Cross Blue Shield national discount, when you talk about how much a provider gets reimbursed, was about 330% of Medicare. So the big discount that the BUCAs give you represents 330% of Medicare, and we're talking about 140% of Medicare. So that's as meaningful. I'm glad that you brought that up, and I want you to talk more about that.
Well, and another thing about the cap is, we price into our product, and we know that there's going to be some negotiation needed. But you also have other claims that are not going to be impacted by the VBP. You've got specialty drugs, you've got other things that, that as stop-loss carriers, we're going to end up reimbursing that are not tied to any kind of Medicare reimbursement. So that risk is already there in the plan.
We're going to talk about drugs later. And I don't mean over at the dispensary. Well, I know who you are, all the people who laughed. I know who's been visiting. So, all right, so we've established our plan. So I want to go to Holly for a second because you've done this. You're the boots on the ground here. How do you educate people? What do you suggest to employers and to brokers relative to how do you educate the employees? How do they buy in? What do you tell them? What's the best way to do it in your experience so far?
Yeah. So we
you know, our philosophy is that you need to be in front of those employees, and you need to give them the why. You need to tell them, look, I may not be able to offer you a benefit program if we continue to see the costs rise in the manner that they are. So let's talk about why we're moving to this strategy and what we're going to do to support you in this strategy. But you have to have your membership come to the table and understand that first and foremost. And I think continuing to educate them, you know, not only when you go to that first employee meeting, because they all kind of look at you glazed, you know, in the employee meeting, but being by their side throughout the whole process, making sure that you have advocacy and the HR team, you know, behind the benefit philosophy, educating members about why we're doing this and what it means to them, and giving them resources so that when they're in that situation, you know, you're helping them through that process, and we're working towards getting them somewhere, you know, to a quality, cost-effective provider who's going to accept some sort of contractual arrangement that makes sense and provide a cost for that service that's appropriate. So definitely the why. We usually do a couple of, you know, we give them some scenarios. You know, dialysis is a great example. You know, 7 years ago, dialysis annually cost $250,000 for a patient. We're seeing those dialysis patients incur $1 million to $1.5 million in claims. You tell those, you know, you tell your membership that and say, look, we're trying to provide you quality care, but we've got to figure out how to get at this. So again, the why.
And by the way, relative to dialysis, you're talking about going from $250,000 to $1 million or more. That's the reason why the people from Renologic are at their booth. So go and talk to them about that, because that's the program. We're seeing 80 and 90% cost reductions.
And more patients, you know,
Yeah.
so it used to not happen to you. Now we're seeing it happen in almost every single employer group. So the reality is it's coming. I mean, it's here. You got to figure out how to get around that or you know, get at that. So, you know, engaging them, telling them, you know, we're here to support you, but this is why we're doing it. I think that is the most important thing.
And then, Holly, if I could jump in, I'm thinking, you know, building along the lines that you are winning the hearts and minds. You know, we've changed up what we've seen even in our patient advocacy center. Some of the communication now that's going out to members is showing them, hey, by the way, did you know this facility is charging you 2,000% of Medicare of what they would accept? Very high level, very simple to win those hearts and minds. It's amazing the turnaround time, because it's always, my employer just has bad insurance. You know, the hospitals, you know, can walk on water, but once you start turning that table around on why you're doing certain things, then the hearts and minds start to change. Because if we all walked in the room and told your employees to say, hey, by the way, we're gonna keep our PPO, but you guys are all good with no bonuses, correct? And then it's, well, hey, no, we need both, you know, from that perspective. So that's where this opportunity lies, to kind of win those hearts and minds, saying, if we're not spending a majority of our dollars in our healthcare spend, well, great, that could be used elsewhere. And we've seen that with, you know, several of our groups, opportunities where it's the second largest line item on their budget sheet is dealing with healthcare expenses. So that's great, but you guys, you're not here to focus on healthcare expenses, you're here to focus on your business and what you do. So that's where it's getting that money back and using it for what you do, your business. And, you know, your workforce is obviously your most critical asset that you have. So having some extra flexibility to be able to do different things and reward and compensate is obviously something big that we see going forward as well.
So just to add to that, what Ryan said, you know, we have 61% of U.S. workers that are covered under a self-funded health plan, and they don't even know it, right? And it's having that plan asset conversation with your employees. The money that is being spent out of that plan belongs to them, and once you have that conversation, they start to care about how they're spending their money, even though it's not in their pocket. It's, you know, when the bucket runs out, the bucket runs out. So it's having that, you know, heart-to-heart conversation about these are plan assets and who they belong to and what they're used for. It's not for me as an employer to go buy a new vehicle. I have one particular client, a steel manufacturing company that's in 11 states. They're kind of like the pioneer of RBP for my book of business. They've been doing it for 7 years. They've been with 3 RBP vendors. They've been with 3 TPAs. Those employees are educated. They have done everything they can in multiple formats to educate the heck out of those folks. If if it would be a Friday night and if somebody were injured and they couldn't get a hold of their HR department, they would call me personally and say, where do I go get my MRI so I don't get balance billed? They totally get it. And I always say to people, I dare you to over-communicate RBP. I just dare you to. So far, it hasn't occurred. So it's a very important piece of this puzzle.
And I'll just add one more thing on to Cori, just so you guys you have an idea point of one of the things that we see, and that the statistic we've heard quite a bit, is 62% of household bankruptcies are due to medical expenses. You guys figured that out, of walking in not knowing what you're paying for and then get financially devastated because obviously they tug on the heartstrings. That really rings it home for a lot of people that, hey, something's got to change a little bit. I don't need to mortgage my house and sell off, liquidate my 401k just to pay for medical expenses that I had no control over as far as cost or understanding what the price was. So that's why we're here, to kind of represent that.
Yeah. All right, we should stop and see. Does anyone have any questions? Anyone want to? We do have a question back there. Thank you very much.
How do you deal with this in rural communities where there's not many
That's a great
providers?
question. Yeah.
I think that's a great question. I've got employer groups here that have run into rural communities. It's like a catch-22, I'll call it. We've had opportunities where we've had one-town hospitals where they will absolutely play ball with us. And it really depends on, I would say, the politics in that area. How many employees and members and dollars are you driving through there is definitely something that comes into play. If it's a two-town hospital, is it we're picking one hospital to play with and kind of pit them against one another? We've done that as well. So you can run into situations where maybe both of them team up against you. So it really depends on what the makeup of the group is, what the dollars are. If you're a 10,000 life group, you can throw your weight around. If you're a 200 life city, you can throw your weight around pretty well too. So it's, the dynamics are different. And then we've even had where we've had 150 life employer group. Well, they're one of the largest donors and have, their name on the wing of the hospital. So once again, it's all about the different aspects. But even still then, they still get pushed back from that regards.
For my clients that are in the rural communities, it's usually about direct contracting. The numbers game is often a fun conversation to have, because if they're very small, like I got 30 lives sitting in the northeast corner of Montana, and they're like, oh, your lives just aren't big enough for us to do a direct contract at Medicare Plus. I'm like, well, that's great. It won't hurt your bottom line. Who do I send the contract to? So you got to play that numbers game both ways, because they just try and use it to their advantage.
And Holly, our clients are where geographically?
Everywhere.
Rural, urban?
Everywhere.
Yeah.
Yeah. So
But let's be real about it. I mean, seriously, you guys, because it's a lot harder. Tell me if I'm wrong on this. Isn't it a lot harder if you're going into a rural community with one hospital to actually do this? And I guess to expand that question, and feel free to say no, by the way, but to expand it, can you share with everybody here where it works and where it hasn't worked, at least to this point, nationally?
Sure. So, I think direct contracting is definitely key when you're running in those rural areas. Like I said, it's the makeup too. We will put what we call direct-to-employer agreements in place with facilities. If we start to notice pushback, we can start to see those things in our system pretty live. So we have a team of contracting folks that can jump in and make that happen. But as far as to what Tom's talking about, experience across the country, stay out of Indiana. That's what I would tell you. So there have been others that have, I would say, scorched the earth and has really tainted the hospitals, and those hospital systems are aggressive. Now, that's not for all. I have Indiana clients. I've got some large unions there, but they have some direct-to-employer relationships with the hospitals from that perspective. So if we do run into those instances, then that's probably the best way to kind of tackle it from that. But that's the number one state I see from our perspective.
Yeah.
And we've had a pocket of Missouri, rural Missouri, where we had a smaller employer group who was accessing care, and there was no problem, no noise. And then we had a very large employer group come into that same area. And suddenly the hospital became aware that, we were affecting their revenue source. And so there started to become some pushback. But I think it goes back to education of employees. Who do you have triaging those phone calls? What can you do collaboratively? We've got great broker, employer partners who are bringing those employees in, having that conversation and saying, we can redirect your care. Let's look at where we can send you. And suddenly those employers go, or those providers go, you're going to redirect care outside of the service area? You're going to affect who's coming into the, into obtaining care here, and that becomes a real question for them. And, they'll come to the table and start talking, at least talking negotiation.
Yeah.
So it's interesting because the smaller groups kind of fly by the radar in some of those rural areas. And it's when you start to see some of this move along, you're going to see some, I think, pushback, and how we triage that's going to be important.
Yeah, we've got business in 23 different states, so rural and major metropolitan areas. But we have seen problems in Indiana, we've seen problems some in New Jersey, we've seen problems in Virginia, parts of California. No surprise on some of those areas. We know that in New Jersey, that the average hospital charges as a percent of Medicare are what, 800% or something? Yeah, so you can see why they get
That's
some
nice.
pushback there. I guess from what I'd like to convey from the stop-loss side is even if you can get it, maybe the direct contract's at 250 of Medicare, that's still a great deal. You're still going to get good discounts from our side of it. And maybe you have to make some adjustments in certain areas. We share a large account, national account, that we've had to make some adjustments in some difficult provider markets and put those employees in a PPO plan in those limited
Yeah,
areas.
and we're going to talk about that in a couple of minutes. as a
Yeah,
matter
but
of fact.
it still ends up over 90% of the group is in a VBP product. So you're still getting significant savings, even if you have to make those kind of adjustments. You don't need to throw out the whole concept just because it's not working in certain areas.
Yeah, for sure. All right, there's a question right back here.
Thank you guys for your time. I appreciate your insights. I represent a group about 340 who went into this just in November. So
Is it a Cypress client?
we are, yes.
Okay, you can
I work for
continue
the
with your
company.
question then. That's
Yeah,
fine.
then you can ask a question.
For now we are.
Oh, ouch. Ouch. Touche.
So just from your guys' exposure, how many employers do you see nationwide, kind of your best guess, are doing this direct to the facilities, doing the RVP to the facilities? How widespread is it? I know we're one, so you go from there. And then secondly, when is the tipping point? You kind of alluded to going to direct relationships and when this does actually impact the revenue, or if Amazon and Berkshire Hathaway come out with something that really disrupts the community and Buka kind of wakes up to this. What do you guys foresee down the road? How long is this lifespan before that it does hit something that really has to make a change?
No, I think
Thank you.
it's a good question. I think we're already seeing that lifespan change quickly now, in the fact that I would say, you asked me 2 years ago, we were flying below the radar on most hospitals. We fly under no radar with any hospital at this point. They're very aware of what's coming through, how it's working. Now, I think one question we haven't asked is, why would a hospital take 140 when they're getting 250, 290, 300, whatever that number is, from that perspective. And I think one of the things that we're always telling the providers is, and one pain point for all you to understand from the providers, they hate chasing your members. So they're one tool for you to kind of, rattle their saber type aspect, but to balance bill your members. So your members come to HR, and then it kind of round robins and creates that mess. That's typically their one perspective they do, but they hate chasing your members. So the most profitable health system in the country, in California, we were talking with them, and they said, hey, if a member owes $1,200, guess what our odds of collecting are? And I'm like, 15%. They said less than 1% is their chance of collecting if someone owes more than that.
$1,200.
So for them, if you can remove them from that collections game, they're all ears to play ball with you. If you can pay your claims quickly, they're all ears to play ball with you. So we require our groups to pay within 7 to 10 business days because of the fact most hospitals or Buka contracts are being reimbursed 45, 60. If it turns into a stop-loss claim, well, that could take a lot longer. So for them, it's really painstaking for them. They provide the service, and they may not get payment for 6 months, a year, depending. So paying them quickly is something that's advantage. But the more direct-to-employer relations, you're going to see a lot of that start picking up pretty quickly with health systems. We're just seeing that across the country. They're starting to understand the opportunities, because right now, if you think about it, they've almost, and I hate to be this direct, but they've got a gun to their head when they operate with networks, where it's like, hey, I've got this membership, you better give me this discount or else type situation. And then you got the network turning around saying, hey, by the way, don't use the hospital for outpatient services, go elsewhere. Go do MRIs, do other things. And that's where a facility makes a good chunk of their money, is on outpatient. That's their revenue source for the most part from what we see.
And Tom, this may be a question for the panel, but I heard a statistic that said that the BUCA relationships are paying large claims, and by the time you net out their discount, that payment equates to anywhere between 400% and 700% of Medicare. So if we can get underneath that 400%, you know, that's huge. We're meeting those big discounts.
You would think it would be. It's up to stop loss people.
I was going to address the question about just how big the marketplace is. And it's really hard to tell. I was reading a recent article that talked about 10% of employers, but there's a lot of ways you can define the reference-based pricing market. A lot of what gets thrown into that is using it for just certain things like dialysis or out-of-network, and sometimes that can be counted as a reference-based pricing client. So it's not necessarily full replacement, sort of like what we're talking here. And as far as just what the timeline is, or how, but the opportunity, we're hoping that the more the providers see it, the more they'll accept it. My fear is, might work the other way.
Yeah.
And we're seeing that in some areas. I think the more they see it, the more they may start fighting against it because it's starting to impact their bottom line. So I hope it's more the former than the latter.
I saw a stat the other day, I think it was on the Kaiser Family Foundation website, that I think it was 48% of employers' plans are using a traditional PPO. Now that's obviously not to say that the 52s use an RBP, but we're under the 50% for a traditional PPO model.
Oh, so there you go. There's a question back there. What happened to you? Oh, there you are, right there.
How much are you seeing, and is it feasible to offer, multiple plan designs? So here's your reference-based, here's your traditional PPO plan for employees, and you're going to pay more for it, you're going to have higher out-of-pocket, and leave it to, at least maybe on training wheels, leave it to the employees to make that decision, or a dual option one plan, and you do the best they can, but they've got the PPO as a fallback.
All right, and before you answer that question, I just want to say, and I'm not here to judge, but I'm really kind of disappointed with this side of the room. Because are you all is this the hangover side? Is that what's going on? Let's step it up here. All right, I'm sorry.
We've seen dual option. I mean, it's for my extremely large groups that we see dual option, probably I would say 6,000 and above. If you start to do it with a 100 and 200 and a 300, 400 life group, then all of a sudden, let's say you've got 70 people enrolled into value-based payments, and then we start to get pushback from a facility, and you're going to say, hey, can you go contract with that facility? And I'm going to be like, well, how many lives are we talking about? And that's when I'm going to say, we've got 70 employees, so when I talk to the hospital, we're trying to have that volume game. But I've seen folks where they have done that dual option to be able to make it the employee's choice from that perspective, but it's been typically on our larger groups where we see that, not on some of the smaller groups, below 1,000 realistically.
I have a perfect example for you. I have a large MIWA client that went full RBP about 3 or 4 years ago, and it was a matter of going RBP or just closing shop and not offering benefits to 1,200 plus members. So they went all in the first year, and there was just chaos with noise from members, and some of these folks are in these rural communities, and it was just maybe not as much education that should have happened on the front end. And so the next plan year, when they were starting to see the savings that they were having, they listened to the feedback from the employer members of the MIWA, and they decided to give them 2 options going into year 2, and they created a traditional PPO model and they created an RBP model, and they rated them accordingly. And they get through the open enrollment, not one employer chose the PPO model.
Ah, wow, there you go. Interesting. Do we have a question? On this side of the
So we're from the lovely state of New Jersey, which you just talked about. So could you maybe talk about a strategy you would utilize going into a market like New Jersey where they're reimbursing 800, 1,000% of Medicare, or what your experience has been negotiating in that state?
Yeah, so for New Jersey, we have quite a few groups that are in New Jersey. We have some that are domicile, and then we also have large national groups that have employees that are there as well. So we're very familiar with the New Jersey area and some kind of their tactics. I mean, for us, it's no different than dealing with California, for instance, of Northern California being some of the most egregious billing, just like New Jersey, we see the same thing. We're very familiar with those hospitals, and then what we do a lot of times when we're looking at groups, we'll actually share what our experience is, so if we can see what their spend's looking like, we can share with you up front what that looks like. Hey, are they accepting? Are they not accepting? What have you guys done in these situations? So we can share that with you too as well. So that way everybody can go in eyes wide open from that perspective. But New Jersey, nothing's sticking out to me of like, oh my gosh, look out, New Jersey. But there's been times when we've ran into facilities for sure where we've had to jump in for negotiations because they are pushing back.
We got a guy down here.
Are you guys seeing situations where there's pushbacks from hospitals where they're getting pressure from the BUCAs, but the pushback, if it's like verbal, I have a situation currently going on like this, where it's window dressing, so to speak, where the hospital is just trying to appease the BUCAs, but behind the scenes, they're still willing to negotiate. They're saying on the front end that they're not, but they actually do behind the scenes just to keep them happy and shut them up.
Yeah, there's a large health system, I think it's number 1 or 2 in the country that is doing that goes around telling everybody, and it's in Tennessee, so you guys can probably figure out who that is. But they go around stating, hey, we're not gonna accept reference pricing. That's the status quo, but behind the scenes, we've seen them accept it all day long. Now it's changed a little bit because some other tactics have been put out there. But we do see hospitals kind of give that status quo of, yeah, we're against reference pricing, but then on the back end, we see them do work with us. So, and then you see letters go out where, hey, I'm not gonna work, we're not gonna accept this. We've got carriers, use one of those, but we're not gonna accept this type model. We've talked to a lot of hospitals, and a lot of times that refers to certain other RBP vendors and the tactics that are taken. So when we, and this is a perfect example, when we are reaching out to facilities when a balance bill has happened, it's to have a conversation so they can understand the numbers. We walk them through all the numbers instead of I could have attorneys call and say you better take it or leave it. So you can imagine how they all of a sudden start to associate reference pricing with attorneys. This is what's going to happen. There's a reason we moved away from reference-based pricing for a very good reason, because hospitals are not big fans of hearing those three letters. So that's why you'll hear value-based payments on our end, and I think everybody in this room knows once you hear that, it's, oh, they must have talked with HST, and I just heard the other day, and one of my competitors is now using the same lingo, and I'm like, fantastic, just what I needed. So, but anyways, that's what we see from the marketplace when you're dealing with hospitals. They'll tell you one thing, but then they can do another behind the scenes.
Yeah. Yeah. I know we've just got a few minutes left, but I want to get to 2 things for sure, and then any other questions we have. Because everyone's gonna, I'm surprised no one's asked the question yet. What kind of savings is this generated? What are you showing? What are you seeing across the country? Are you willing to tell us?
Sure. So these guys at Cypress have seen, under the covers on, their block of business and how we do what we do from that perspective. Our realistic discount right now on 140% of Medicare on our block of business, just as of right now, is about 76%. Is where we sit on billed charges, so that's relative to Medicare at 140. I would say our average is averaging about 70% is where we see it. Now, does that apply to every single state? No, if we're in Utah, for instance, we're gonna be in that 50 range because that's where it sits, because the facilities aren't as egregious in that area. I think Nebraska is another area where you're not gonna see a 70, you'll be better off than, and I know, Jim can relate to this too as well, but you're not going to see that 70% discount, but you'll still see a significant discount above where a network or a PPO would be.
All right, so let's repeat that. I can tell you for our block of business, admittedly not massive, but it's fairly large, I think relatively speaking, 76% discount off of billed charges at the hospital. That's meaningful numbers. And Holly, you were telling me this morning about some interesting numbers.
So 76% on the claims that are running through, but I think most importantly, Tom showed you what our book of business is running on a per employee per month spend. On the reference-based clients, though that per employee per month spend is in excess of 25 to 35% lower than that number. So those reference-based clients are contributing to that, but they're all in total per employee per month spend is running significantly lower. We're already 40% lower than the average on our book of business, and then the reference-based clients are coming in at between 25 and 35% lower than
And that's overall spend. That's
Overall
not just on
spend.
the hospital.
Right, so we're talking about the hospital claims, and people are like, oh, you're mitigating that because you're, putting in the network or you're, driving them to other network contractual arrangements. No, we're not.
Yeah, and so we're talking about actually lowering your healthcare costs by 30 or 40%, lowering overall costs, not just the hospital costs. So I guess the decision you have to make is, how much is the pain of going through this worth it? That really is something only you can answer. But just for some perspective, Cori, one of the things I did want to get to is, so what happens when you have a hospital that's balance billing the patient? $1,200, $300,000. We saw a $300,000 balance bill at one point. What recourse do they have?
And typical lawyer answer, it depends. It depends where they're located. It depends on the scenario. It depends what my administrative record looks like that I'm dealing with. Depends on the amounts. I'll give you a couple kind of recent cases that are always at the top of my mind that worked out very well. So we had a $1.2 million claim out of the state of Denver, and it was an out-of-network claim that the RBP would have been, state of Denver. I didn't even drink that much.
That much.
And I'm even on the money, okay? In Colorado, and $1.2 million out-of-network claim. The RBP language in the plan was 200% of Medicare. And I had this TPA call me up and say, oh my gosh, they just called and they're willing to do a direct contract. And I'm like, okay, well, we have to answer them by tomorrow. I'm like, okay, what's the number? 10% off billed. And I'm like, are you kidding me? So I said to the TPA, get ready to cut the check. I'll draft a letter that goes with it. I called the employer. I got information about the employee who was no longer an employee, and he just signed up for Medicaid. I sent a letter to the facility with their $160,000 check and said, here's your money according to the plan. Here's a copy of the plan. This represents 200% of Medicare. The patient just signed up for Medicaid. He's no longer an employee. Have a good day. I sent a letter to the employee, and I called the employee, and I said, this payment has been made. According to the financial assistance policy of the facility in the state of Colorado and your income, they are required to write the balance off. If you ever hear from them by phone or by letter, you call me on my cell phone. And we've never heard from anybody. Another example that was with HST last month maybe, we had a member that lived in the state of California, got it right this time, state of California, and was on vacation. Ends up in the state of Virginia and ends up in an ER and ends up with a bill at 9,000% of Medicare. The state of Virginia, at least this one particular facility, they have a new approach, and this is where things are always changing and we just got to stay on top of it and we can't give up. This particular facility, they don't balance bill and then send people to collections. They have a warrant in debt process on this statute in this particular area where they just sue the patients. And so this patient got a summons to appear in court in Virginia at the end of March and obviously called the employer who then called HST who then called me, like, what are we going to do with this? And I'm like, okay, give me all the information and I'll see what I can do. So I go straight to the CEO of the facility and she hands me down one ring on the ladder and I get this gal and I said, can we have a phone call? And she said, yeah. And it's all about being prepared for the conversations. I said, okay, I just want to lay this out for you. We have a patient that lives in California that's traveling through your great state on vacation. She's a cancer patient. She ends up in your facility. You treat her. You bill her 9,000% of what Medicare would reimburse. She goes home. Her plan pays what it is legally obligated to pay, and no more and no less. And you balance bill her, and now you're suing her in court, and you're going to make the cancer patient come back to Virginia to defend herself for your egregious billing? How do you people sleep? And the case was settled within 2 days. So it's just a matter of having those conversations like, are you kidding me? And there's a lot of facilities, it took a while for facilities to figure out what we're doing, right? My one longest client is 7 years into RBP, and for some of those facilities, just within the last year, they're like, oh gosh, we have all this accounts receivable on our books, what is going on? And so it starts the conversation, it allows opportunities to contract on the front end or on the back end. And there's no one situation that looks alike. We have a situation, I think, in Maryland right now, and this is not RBP related. This is just their general practice. It's a small town, one hospital. They don't go to collections either. They garnish the wages. I have a second opinion company with Dr. Marty McCary, he's into all this stuff. He gets all excited. He went and talked to all the patients that had had their wages garnished. 25% of the entire community has had their wages garnished by the facility in which they seek care. That's an important public service announcement, right? So it's just a matter of kind of peeling back the layers of the onion and exposing it for what it is, and then doing the best we can to get these claims settled for the patients. And there's a variety of tactics that we have to use to get there.
Yeah, and you got to get buy-in from the patient too, right? And Holly, we've got experience with people who actually have sort of decided they're going to go the distance, right? Do you recall? I'm trying to think of last year we had somebody who was actually an owner of the company, I think, who just was like, we're going to go the distance on this.
We're fighting. And I think, obviously, people like Cori are helping that cause tremendously. In that situation, they're saying we're 10% off bill charge. And I think just putting a legal entity in front of them says, hey, we're willing to fight back. And some employers, have talked to us a little bit about putting the onus on the member. Most employers aren't willing to do that, obviously. But we talked a little bit about, sometimes educating the employees up front and telling them what's all involved, having the employee go to the table and negotiate. Once they understand that the employer is out, maybe you're supporting that employee on the back end. But the reality is sometimes your employees have more bargaining power than you do because they know that they don't have deep pockets. So that strategy has been talked about a lot, and I think you'll see that kind of come to fruition.
And I think one thing that public opinion is definitely something that can, I would say, persuade a lot of facilities. I think, let's take a perfect example, EpiPen. All of a sudden there was this uproar, everybody got mad, and sure enough, lo and behold, prices came down. So the biggest thing hospitals are absolutely scared of is this room and in here and everybody understanding what's going on in the game to be played. And if all of a sudden you start making decisions based on cost and quality, it's not that unlimited check that's coming in for them. And so if things start to leak out, for instance, Sutter in California, destroying documents on pricing and things like that, well, that probably doesn't look so good. But when that starts to, a lot of people don't know about that. It's very few and far between, so it's mostly insurance experts who know about it. When employees start to understand what's going on, then public opinion can sway a lot of things. And I think that's what we all need to understand too as well.
I'm with you. All right, we got about 2 minutes. I'm going to give one last opportunity for this side. There's a question over here. God bless you.
I'm representing the hangover section, apparently. Holly, you mentioned the difference between, or maybe the employee having more power, more negotiating power than the employer. Do you guys have any experience with the employer saying behind the scenes, I'll reimburse you, I'll take care of you, to their employee after the fact?
Yeah, we've had a few cases where they said, go to the table, see what you can do. We'll help you, in that negotiation. We were just talking about, what does that look like legally and how can employers do that? And I think we've established that there's no reason why you can't let your employees, go to the table and help you negotiate with those providers. It's the pocket of money that they have access to, so you're empowering them to empower the plan. So we haven't had a whole lot. Like I said, employers are much more member-centric than we give you all credit for, which is a beautiful thing. I mean, the integrity of your benefit program is important, obviously, from a retention perspective. And you don't want to see your members suffer from that perspective. But I think, again, educating them and making them a part of the game and help you play in that space makes a lot of sense.
All right, one last one. Anyone have anything? I've got one. Here's one right there.
The question I have for you is, well, actually twofold. When your member happens to have secondary coverage and the primary coverage facility does not play in this game, and then how do you deal with the remaining balance for my member? And then also, how do you interface or relate with centers of excellence that have contracted prices for certain procedures?
I can speak to the Centers of Excellence. We think it's important, that you integrate those programs whenever possible. You want your cancer patients to go to cancer, or, to be integrated with somebody from a navigation and a contractual perspective. They have contracts with Centers of Excellence. Dialysis patients with Renologic. They're supporting those patients. Transplants.
Yeah.
Transplants. We're telling you, don't even put in the program unless you're at least contracting those services. And most of the stop loss carriers understand that those contractual arrangements are appropriate from a billing and payment perspective. So they're supporting that. So from that perspective, we're advising that people put in those programs and integrate those programs. And again, let Ryan's team take care of the all other, the big hospital egregious facility claims that we're trying to deal with.
I can answer that offline too for you too as well. I'd be glad to.
Yeah. So we have run an hour, 1 minute over. We could probably do this for another hour, but in the interest of time, obviously we're not going to do this. But this is really interesting stuff, and I think everybody is willing to look at it, consider what you need to do. These are the experts. Talk to them. They're going to be around, so I suspect there's going to be a lot more conversation. But in the meantime, thanks so much for everything you've done.